Chronic granulomatous disease is one of those conditions in which the ability of white blood cells to kill invaders, mostly bacteria and fungi, is impaired. And it's impaired because normally cells are supposed to make bleach in order to kill things. Now, the way bleach works here is a little complicated. It's more like a signal than like an actual killing agent. But that signal gets disrupted, and when that signal doesn't get sent right, the cells don't kill bacteria and fungi properly. And so what happens is that patients with CGD develop bad infections, and those bad infections can be serious and fatal. In addition, though, what makes these immune deficiencies so complicated is that not only do they get bad infections, they can also get bad inflammatory problems. And by that I mean things like inflammatory bowel disease, inflammatory lung disease, some skin conditions, all of which really are sometimes referred to as autoimmune or autoinflammatory type problems. CGD is an inborn problem, so people have it from the moment they're born. And yet it takes some time for it to show up. Usually, in the more severe forms, it shows up before 1 year of life in boys. And it can show up as an infection, can show up as inflammatory bowel disease or severe diarrhea, sometimes shows up as problems with swallowing or with eating. And then some of the later manifestations can be infections, diarrhea, failure to grow normally. Usually, most cases are diagnosed in childhood before about age 5. However, there are people who have milder forms who show up later in life, and people can be diagnosed in adolescence, in adulthood, sometimes even in late adulthood. And the oldest known patient who was diagnosed with CGD is 69.
CGD is a defect of neutrophil function and not number. So patients with CGD may have completely normal neutrophil counts, and often they do. You would not typically see neutropenia in patients with CGD. However, the neutrophils don't function normally. And in the most severe forms of the disease, the bacteria can be engulfed by the neutrophil, but the neutrophil cannot kill the bacteria. So what this leads to is large granulomas, hence the name, as well as pus pockets or abscesses, which can be found in any organ, most notably the liver, the lung, the skin. And this leads to bacteria that are walled off but not killed, and ultimately those bacteria then find their way either into other organs or into the bloodstream where they cause severe illness.
Early diagnosis of CGD is very important because there are fantastic drugs we have now that we didn't used to have that can help prevent a lot of these infections and decrease morbidity and mortality in these patients. And so now with great antifungals, which have really changed the way CGD is managed. Patients are living longer, they're staying healthier. And also with early diagnosis, definitive curative treatment such as bone marrow transplant is actually an option for some of these patients depending on the circumstance. And earlier transplant in CGD has far better outcomes than later transplant because you're catching them early before they have liver abscesses or other fungal infections that could make transplant later complicated when they're immunosuppressed for the transplant. So we have a patient right now at our hospital who is diagnosed based on family history right at birth, and he has been managed on fantastic medications, including interferon therapy, as well as antifungals and sulfa antibiotics, and he has been completely infection-free for over a year. I think that the early diagnosis really made a big difference.
Patients who present with CGD, especially the boys who have the X-linked CGD, often present early. And by early, I can mean as early as infancy. They can present with severe infections or unusual infections. Severe infections can be internal organs that develop a bacterial infection or a fungal infection. These can be in the liver, in the spleen, in the kidneys, in the blood, and even in the brain, like a meningitis. So some of these infections are quite serious. The children need hospitalization, IV antibiotics, surgeries to remove the infected tissues. It can be quite life-threatening right from a young age onwards. The reason it presents so early and so intensely in those boys is because they only have one copy of an X chromosome, and the copy that they have of that X chromosome bears the broken gene. They have no backup plan. So all of their cells, all of their white blood cells, lack the ability to kill certain kinds of bacterial infections. So pediatricians should be alert for any patients who have severe disease, severe infection, what we call opportunistic infections, which are unusual infections with organisms that don't normally occur in healthy children. These include fungi and unusual bacteria.
CGD can present in a variety of ways. The most common way that we pick it up or start to think about CGD is a young child that has an invasive infection that's usually due to one of the organisms that we know are commonly seen in children and adults with CGD. So there are a series of germs that we know folks with CGD are very predisposed to infections with. And the main ones are the bacteria Staph aureus, Staphylococcus aureus, and then there's a mold called Aspergillus, and a few other bacteria called Nocardia or Serratia, and then Burkholderia. And that list, those 5 organisms actually cause the vast majority of CGD-related infections in the United States.
I go back to the example of Burkholderia cepacia. If an immunocompetent patient showed up with a low-grade fever and flu-like symptoms, I would probably say go home and drink lots of water and drink chicken soup. If a patient with CGD showed up with those identical symptoms, I would tell them you have to go to the emergency room and get a blood culture. I'm worried that you might have a Burkholderia cepacia bloodstream infection that could kill you very quickly.
So traditionally, we thought that the female carriers of X-linked CGD were relatively asymptomatic. It's true that an X-linked affected boy could have developed his disease from a de novo mutation, but usually the trait is inherited from his mom. There's much growing evidence to show that these female carriers are quite symptomatic. And recent work from the NIH showed that when their enzyme activity, their oxidative burst drops below 20%, they are at increased risk for developing the same kinds of infectious complications that the X-linked CGD boys can develop. What's also been shown, however, by multiple groups throughout the world is that these X-linked carrier females can start developing autoimmune disease even when the amount of the respiratory burst is still above 20%. Why this is, we don't know, but we do know that the respiratory burst, which is related to inflammation and protection from free radicals, it's no big surprise then that when something goes awry in this system, that autoimmune complications occur.
Other unrecognized complications of CGD are the autoimmune complications. So these patients can present with vasculitis and granulomas almost anywhere in the body in terms of a Crohn's-like colitis, pyloric stenosis from granulomas in the pylorus, granulomas in the vocal cords, in the sinuses, in the lungs, in the bones. So the inflammatory complications related to CGD often go unrecognized and misdiagnosed as other granulomatous or autoimmune syndromes. But especially in the United States, since 70% of the patients have X-linked CGD and are boys, any patient, especially boys, that present with severe autoimmune complications should be screened for chronic granulomatous disease. So although this is a rare disease, right now I think the statistics are about 1 in 250,000 in the United States. It's not rare for the patients, and it's not rare for the patient's family. It's what they live with. So it's important to keep CGD on the differential for any of these inflammatory or infectious complications, because the earlier that it's diagnosed and the earlier that therapeutic interventions can be implemented, the better the outcome for the patient. And early diagnosis, early intervention, and treatment and resolution of infection and autoimmune complications are very key to the referral for bone marrow transplant, because these patients' outcomes are better if they come to transplant healthy without severe infection or autoimmune complications. And their lifelong survival is better if all of these are under control, taken care of, and diagnosed early.
Increasingly, we're recognizing that abscesses in other organs, like the liver, can be a very serious complications in CGD. And this is being recognized as patients are living longer with CGD. We're doing a better job of antibiotic prophylaxis. But even despite antibiotic prophylaxis, liver abscess can emerge and tends to emerge in patients with CGD, and we do not have. We're still learning what the best treatment approach is for those patients. There is a significant morbidity associated with abscesses of the liver in patients with CGD.
Whenever we're taking care of patients with primary immunodeficiencies, a team effort is needed. Oftentimes these children live far away from the actual immunologists, and so we immunologists rely on the local pediatricians to help us with the day-to-day management of the patients. That can include being able to see children quickly when they present with fevers or other illnesses. That can also include making sure that nurses are available to teach the patients how to use their medicines properly.
There are a few aspects of caring for a patient with CGD that are important to keep in mind. Some unique features. This is a relatively rare disease, and one of the things that's unique about it is this relatively small list of pathogens that frequently cause disease in CGD. Even though the neutrophil is a major component of host defense, and even though the neutrophil is involved in the clearance of many types of organisms, it's really only about 5 pathogens that cause the bulk of infectious disease in these patients. And for that reason, we've been able to become pretty effective with prevention of these infections.
Lifestyle modifications matter, so patients with CGD are most susceptible to certain bacteria and certain fungus that can be found in the environment. So we always caution our CGD patients that they limit exposure to areas where certain types of fungus or mold might come into contact in the air. And so places like that are found in sort of warm, humid environments like barns or caves, or when houses are undergoing renovation. So our CGD patients should never be in those kinds of environment. The other place that we run into a lot, being from Florida, is fresh water and brackish water specifically. So brackish water is when salt water and fresh water meet. The salinity can change of the water itself, but certain bacteria grow in that environment and can be very life-threatening in CGD patients should they become infected with those bacteria. And so we caution our patients that they should not swim in those environments. So those are some of the considerations that families have to take and healthcare providers need to caution their patients about.
So the standard of therapy for patients with CGD is to start on prophylactic therapies. These have to be an antifungal, such as itraconazole, that's the one that's been most studied, and some kind of antibiotic that will help prevent the development of Burkholderia serratia in staph. And so most commonly in patients who are able to tolerate, Bactrim is the drug of choice. These are for standard management. The other thing that we recommend is that they have frequent exams followed up at a center, and frequent imaging, even though people worry about the exposure of radiation, given that a lot of patients end up with asymptomatic fungal infections or pneumonias of considerable size, we think that prophylactic imaging is of benefit.
The third element in the triad of things for prophylaxis for CGD patients is gamma interferon. There was a double-blinded study conducted in 1989 which showed that 3 times a week use of gamma interferon can reduce the frequency of infection. To be fair, we still don't know exactly how it does that. We think that it's, in a very general way, increases the surveillance of the immune system. But there's a price to pay. Some patients may get fevers with this, although In most cases, those fevers may subside over long-term use. Some patients may get nightmares, have trouble concentrating, and so on. And although there's a standard amount that's recommended, at least at the NIH, we would rather see someone take the gamma interferon than not, and so we'll work with them. We'll lower the dose, we'll lower the frequency. Important to know that we don't have data about what happens when you lower the dose or lower the frequency in terms of protective effect, but we think that this still provides protective effect.
Caring for patients with CGD can be difficult. They get sick often, and those infections can be severe. So having a team that helps care for these patients is essential. That includes primary care to check on general health and be the first call if that patient is concerned they have an infection. But primary care physicians are going to need support because these patients are rare and it can be difficult to anticipate what they will do next. And so having immunology and infectious disease and bone marrow transplant to offer a full range of care for these patients is essential. In addition, having support services, including home health and social work, can help address any barriers to care and help patients maintain compliance with their prophylactic antibiotics. I think one of the things that physicians need to understand about CGD is because it's so rare, a lot of patients can feel very isolated in their diagnosis. Helping patients feel that they are connected to a community can be essential to helping them accept their diagnosis and also making sure that they have access to supportive services, to behavioral health is really essential, especially as they become older and become teenagers and transition to young adulthood.
So bone marrow transplant is a therapy that can be used for some patients with chronic granulomatous disease. The process of bone marrow transplantation involves replacing the bone marrow and the immune system of the patient receiving the transplant. In the case of chronic granulomatous disease, it is a deficient immune system or white cells that are important for fighting infection that do not work well. Through bone marrow transplant, we're able to replace the patient's own bone marrow and immune system with the bone marrow and immune system from a donor whose white cells work correctly, have normal oxidase activity, and would be able to eliminate any infections that the patient may have. Although bone marrow transplant is curative of chronic granulomatous disease, or CGD, we do not use this modality for all patients. With bone marrow transplantation, there are a lot of risks that are involved that can place the patient at risk for complications. The decision of which patients need to go to bone marrow transplant with chronic granulomatous disease requires discussion between the patient and the multiple specialists, including the bone marrow transplant physician, to decide if bone marrow transplant is really the best option for patients with chronic granulomatous disease.
When we think about bone marrow transplant and its risks and benefits, I think we have to think about a few things. We have to think about the status of the health of the patient who's going to be getting the bone marrow transplant. We have to think about what the donor options are that we have available to us. Certainly we see the best outcomes across the board in almost every form of transplant if the patient has a matched sibling donor available. And then coming in as a close second is when there are matched unrelated donors, either adult unrelated donors who are full matches or cord blood unrelated donors who are full matches. I think it becomes a little more tricky when there's nobody who's a full match to the patient and we have to consider using a half-matched relative, which would typically be a parent, because our risks of graft versus host disease, the more we're mismatched, can become higher.
Bone marrow transplantation in CGD has come a long way. As recently as 10, 15 years ago, it was really considered an experimental therapy for CGD, and now for especially for X-linked CGD, it is considered this standard of care. For bone marrow transplantation, the success rate of bone marrow transplantation is dependent on a number of factors. The first factor is finding an appropriate match. So if a patient has a full sibling, they have a 25% likelihood of being a full match. And the better the match, the better the outcomes. Number two, the older the patients are, the less likely the transplant is to be successful. And that is typically due to a number of factors, including permanent end organ damage that results from recurrent infections the longer you wait.
Gene therapy and the future of that as a treatment modality for chronic granulomatous disease. I'll just summarize by saying that in the past, I don't think we had the kinds of vectors that were either safe enough or effective enough to make this a reality for CGD. But we're in a new era of gene therapy. The use of what are called lentivirus vectors, which seem to be very effective at getting genes into the true long-term repopulating stem cells. And there have been some singular successes now using lentivectors for gene therapy in such disorders as Wiskott-Aldrich syndrome, in some of the inherited disorders of lysosome storage, and in adenosine deaminase skid. Over the past couple of years, many groups have been working toward developing lentivectors for the X-linked form of CGD. I'm very fortunate to have collaborators in the UK and across Europe, as well as across the US, and many of us have gotten together to work on a clinical trial of gene therapy using a particular lentivector that appears to be quite effective. Some of this work has already been presented, and there'll be an abstract presentation at the American Society for Gene and Cell Therapy this May, in which some of the early results of the combined European and US studies have shown that we can, in fact, provide substantial clinical benefit to patients with X-linked form of CGD in terms of long-term correction of the hydrogen peroxide producing capability of circulating neutrophils. This is still highly experimental. The making of vectors and the doing of this is still quite complex. It's not quite ready to be available to the whole world, but I think that within the next 4 to 5 years at most, gene therapy will be an available treatment modality for patients with the X-linked form of CGD. We and others are focusing on the other kinds of CGD, particularly the next most common p47 FOX deficient autosomal recessive CGD, but clinical trials are not open for that yet. But we hope that perhaps in the next year or two that trials for that form of CGD will also be open. So we're pretty excited about this. We like to be our own competitors, and although we are fans of the lentivector gene therapy for CGD, we are very excited about the prospects of gene editing, which is a way of not using viral vectors that just insert all over the genome, but rather to actually repair the actual gene that is deficient in X-linked chronic granulomatous disease. And there's been quite a bit of progress in our lab and other labs at going in and using things like CRISPR to specifically repair the gene that normally makes the missing protein in X-linked CGD. We've also in our lab been looking and have had some success in the laboratory with CRISPR gene editing at fixing the p47 form of CGD. You know, my hope is that we will have competitive methods over the next 5 or 6 years. My hope is that one of them will be even better than the other. I can't say that lentivector is going to be replaced by gene editing, but it's our hope that we have more than one way of approaching gene correction of CGD. So as with any treatment or biologic, our hope is that all patients treated would have spectacular success. But in reality, what we find is that we have a percent, and our hope is that we'll continue to see an 80 or greater % rate of patients who dramatically benefit from this gene therapy. Where do I see the future standard of care for CGD patients? It's important that I emphasize the fact that CGD patients vary. Some have severe deficiencies in their oxidase activity and their production of hydrogen peroxide. Some make a significant amount of residual hydrogen peroxide and may have mild forms of the disease. Some who have the mild form of the disease in terms of production of oxidases may have fewer infections, but surprisingly may still have a lot of inflammatory problems. I think that more and more we're going to tailor our standard of care to the specific patients and come up with algorithms, with ways of analyzing what we do for an individual patient and say, this patient should just stay on the prophylactic antibiotics and the gamma interferon. This patient should go to regular transplant. This patient should now do gene therapy. So I think that the future that I see is one in which we not only have new ways of treating CGD patients, but better ways of judging which patient should get what kind of treatment.
Gene therapy is on the horizon, and we ourselves have a study ongoing looking at the effects of gene therapy. And then eventually we think that gene editing will play a role in treating patients with CGD.
Patients with CGD do really need a multidisciplinary approach to take care of them. And they're not a patient that that any one person can take care of by themselves. And I can tell you that at our institution, the average person with CGD will have 3 or 4 people interacting with them. We have infectious disease doctors who are in there helping us work up any fevers, any new infectious symptoms. They help us prescribe the antimicrobials that are needed. Oftentimes GI doctors are involved because of the inflammatory bowel disease. Sometimes our urologists are involved because of the granulomas that can happen in the genital urinary tract system. And it really is a disease that can affect any aspect of your body. And so it really is a disease that there needs to be a close niche team that helps to take care of that patient. One of the takeaways would be is that there's a lot of physicians that a patient may see, and oftentimes these patients with CGD are quite sick and nobody's able to quite put a finger onto why they're so sick. And one of the important things is being aware of this disease, being aware of the manifestations, and then being able to get them to a place that can make the diagnosis and eventually treat the disease, and being aware of the places that those are really some of the take-homes in order to help our patient outcomes.